So up until very recently, most of the therapies were small molecule inhibitors, right? So now these biologics are becoming very, very important part of therapy. Okay, so in very simple words, small molecules are the ones which we synthesize in the lab, right? These are small molecules. They are usually small in size, but they can be big in size. But as long as they are synthesized in the lab, even if they're bigger in size, they are still considered small molecules. Okay, so you can build this big of a molecule, okay, with pretty big molecular weight size. It is still small molecule because biologics are really big as compared to these molecules. So look at aspirin, it has 21 atoms. Look at antibody, it has 25,000 atoms. So biologics are extremely big. It's like you are comparing a bike with a, with a huge aeroplane, right? Other definition is that biologics, as the name suggests, they're originating from biological material. They are not chemically synthesized. So they could be DNA, RNA, or it could be that you're making biologics in E. coli or in some organism. Okay, you're producing the protein. Okay, so what is the pros and cons, and what are so how are these small molecules and biologics important for us, and what are the strengths and the weaknesses of both of these class of compounds? So the goal is simple, that for precision medicine we have to find the right drug for the right patient at the right time. Okay, so let's look at small molecules and biologics. Okay, so small molecules are the traditional backbone of medicine, of course, representing over 90% of the drugs on the market. They are chemically synthesized pills, which we are most familiar with. Biologics are the modern revolution and the fastest growing sector, derived from living organisms. These complex molecules treat diseases previously thought untreatable. Biologics are so important. All the challenges faced by small molecules can be addressed by biologics. How many, do you guys know of anyone who is undergoing immunotherapy? Anyone? You guys don't know. That is very good news that you don't know anyone personally who is undergoing immunotherapy. Immunotherapy is all biologics. Okay, the bad thing about biologic, the couple of bad things about biologics is that it is very expensive compared to small molecules. It's very expensive, and the reason why it is very expensive is that because you have to produce it the way they are produced, but more importantly, they can denature very easily, right? So storage and everything is stability is a big issue. So that is why they are very expensive. Okay, but they are extremely useful. So drugs with a low molecular weight, usually less than 900 daltons, but even if it is 2 kilodalton, it is still small molecule inhibitor. Chemically synthesized in labs, stable, defined, predictable. You can make the compound over and over and over and over again anywhere in the world. It's going to be identical. So that's the beauty of chemical synthesis. You can make exactly the same compound no matter where you make in the world, right, with the same purity. But when you make a protein biologic kind of thing, there is always batch to batch variability. You cannot control that. Okay, not to the extent you can control the chemical synthesis. Okay, aspirin, statin, kinase inhibitor, Gleevec, they all come under this thing. Biologics are drugs with higher molecular weight, higher than 1,000 to 150,000 daltons. They are manufactured in living systems, bacteria, yeast, mammalian cells, complex heterogeneous folded proteins. I'm going to give you many examples of that. Okay, so this is just to show you that small molecules usually have 2,200 atoms, and biologics have just enormous number of atoms. Okay, so small molecules usually, not always, they fit in the active site of the enzyme. Okay, so this is the normal enzyme which is binding a cofactor, but small molecule inhibitor will kick this thing out and bind it here. Okay, so it's like a lock and key. Yesterday I was telling you about PROTACs, right? today I'm going to tell you about PROTACs in great details, and you are going to really love that thing. So what happens is that, so many times, let's say there is a protein, right? So let's say this is a kinase. Kinase is, you know, like BCR-ABL or any other kinase. So let's talk about some other kinase. Let's talk about Aurora kinase, right? So this is the active site of Aurora A, and if you inhibit it, Aurora is overexpressed in every known human cancer. So if you inhibit it, you are shutting down Aurora A activity, correct? And so cancer should reverse. So that is one option. But it is also shown recently that Aurora A binds with MYC and stabilizes MYC, and it has nothing to do with its catalytic site. It is just binding is stabilizing it. So now even if you inhibit Aurora A activity, MYC is still going to be stabilized because Aurora is bound to it, right? And yesterday I told you how bad is MYC, correct? So Aurora inhibition is not sufficient. So what do you do now? You make Aurora disappear completely. You degrade Aurora, and PROTACs is a wonderful tool to degrade the protein completely. So protein is made, and you just degrade it at your will. Okay, and this method was developed by Craig Cruz in early 2000, and it rose so rapidly that there are many PROTACs in clinical trials right now. Okay, so detailed mechanism later, but this is your protein of interest. And also there is another thing why PROTACs are very useful. So kinases, they at least have an active site, and you can make a small molecular inhibitor for it. But there are many proteins which have no active site, like MYC. How do you make a small molecule which has no hole or something where anything can fit? These are undruggable targets. Degradation works for them equally well, right? So the best part of PROTAC is also that any undruggable thing can be degraded, right? So this is a protein of interest which is considered undruggable because there is no pocket for small molecular degrade. So you make another thing, small molecular degrader or PROTAC, okay? So how many of you have heard of ubiquitination? Is there anyone who has not heard of ubiquitination? You have not. So ubiquitination was discovered, I think, in 1990s. And so what it does, it was, those people got Nobel Prize. So they were asked to explain their research in layman's terms so that the rest of the world could understand. So they said it is a kiss of a death. So if this is a protein, and you ubiquitinate it, then this is like tagged for degradation. So if you put a ubiquitin group, then will go to the proteasome. Proteasome will recognize the tag, and basically it will be degraded, and all the amino acids will be recycled, right? So that time this was correct, but ubiquitination also, there are of many varieties, so there are different things, will not go there, will stick with classical ubiquitination. So basically if you put the ubiquitin, then it will be degraded. Is a tag. Ubiquitin is a very small protein, and it's like 72 mer or something, and you put first ubiquitin and then the second ubiquitin and the third and the fourth and the fifth and the sixth and the seventh, small chain, and proteasome will recognize it, eat up. And proteasome is like a barrel. The protein will go inside, and here the chopped pieces will come out.
It contains proteolytic enzymes.
It has a lot of those inside.
Because I heard we use this proteasome inhibitors.
You use proteasome inhibitors, you have to use that. Yeah. So this is in very simple terms. What is this thing, right? So there are these enzymes called ubiquitin ligases which tag the protein. So there are three of them, E1, E2, E3, and they are called ubiquitination machinery is brought up. So basically what you do that, so you don't even need to attach ubiquitin. So idea is very simple. Let's say this is a protein I want to degrade, and this is E1, E2, E3 proteins. So if I even bring them in close proximity, it will get because they will put ubiquitin there, and this will be tagged for degradation, right? So what you do is that you make a small molecule which will bind this protein of interest. It has to have a pocket for that, right? So it will bind that protein of interest, and the other part will bind this E1, E2, E3, one of them, and then it will come close to that, and then it will degrade it. Is it making sense? Right? So this is what is shown here, this small molecule degrader. This is ubiquitin ligase, which is bound to E2 and E3. So usually what you do is that you make a compound which binds your protein of interest and E3 ligase, not E1 or E2, E3, they are all together. So then you bring them in close contact, and E2 will put the ubiquitin thing, and it gets degraded. Okay, so it is not making sense. I have complete like structures and everything, but basically you tag the protein for degradation. So what happens is that if ubiquitin is added, it will be eventually degraded. Ubiquitin is added by E1, E2, E3 enzymes. There are 3 different enzymes altogether. So if you bring E1, E2, E3 next to the protein of interest, ubiquitin will be added, and this will be degraded by proteasome. Okay. So how do you bring these two guys together? You make a bifunctional compound. On one end, it is binding your protein of interest. The other one is binding the E1, E2, E3 complex, particularly E3. Is it making sense? And that's how it is degraded. Okay. So let's look at the success story of Gleevec. Okay. So keep in mind, we are in the small molecule arena here. So we will talk about both simple small molecules and PROTACs later on. Okay. So this is just a simple molecule. Gleevec binds in the active site, and we know how successful that was, right? So what is the advantage of small molecules? The pros: it is orally bioavailable. You just take a pill, it works. It can, because it is a small molecule, it can penetrate deep in the tissue, right? So no matter how big is the tumor, it will go all the way inside. It is usually very cheap. You know, Gleevec, when it came out, it was very expensive. I don't know how expensive, but I'm guessing it was very, very, very expensive. It is not that making the compound is expensive, because probably we can make it in less than whatever, 5,000 rupees. Right? But the drug would be 50,000 rupees, because billions of dollars were spent in identifying that. So they have to get that money back. And that is why the drug cost is so high initially, till it becomes generic, and then everyone can synthesize it. But they are still very cheap. Okay? Then they usually cross the blood-brain barrier. So if somebody has brain cancer, it will cross the blood-brain barrier and it will reach there. So these are all the advantages, but they also have a lot of disadvantages. The biggest disadvantages are, because these molecules are simple, they often have side effects. They often have cross-reactivity. So it's usually very hard to make a monospecific inhibitor which will only inhibit one target. It will inhibit multiple targets. They also have short half-life because they are so small. They are just metabolized and cleared quickly by the body. So you have to take daily, sometimes 3 times a day, like we take antibiotics 3 times a day, right? When someone is given immunotherapy, they give you once in 3 weeks or once in a month. It stays that long. Okay, but antibiotics, how many times we have to take for 10 days? 30 times, right? 3 times a day for 10 days. Okay, so I included this because this is something I was telling you guys, and I said CETSA something. CETSA is a thermal assay. It is ISA actually, but it is a small molecule thing, so I had to show you guys what this is. This is the one, remember I was telling you, you open up the whole brickload of assembly and you kill the cancer cells. This is what it is, ISA. Okay, but this is small molecule. So what you do is that you take small molecules selectively to target cancer cells, and then some enzymes will make a supramolecule thing. So you add small molecules, and cancer cells express this alkaline phosphatase. So all of these small molecules will accumulate there, and they will form a supramolecular structure there. Okay, once they make that structure, Now the cancer cells, on top of cancer cells, the whole assembly will disassemble. So it's like you take a truck load of bricks and it will go to cancer cells and it just throws all the things right there. And then it will kill that. And once it kills them, all the tumor antigens will be out and the immune response will also be triggered to clean it up. So why I am so excited about this approach? Because this is like physically going there and killing everything at once. Like cancer cells should not have time to respond because then they will develop resistance. So you have to just use a magic shotgun so fast, kill everything quickly enough. Okay, now let's come to biologics. So biologics have to be vaccines. You know, vaccines are produced cells, tissues, recombinant proteins, DNA or RNA. Okay, so what is the key characteristic? Large molecules like enzymes, cytokines, antibodies. They're produced in living organisms, bacteria, yeast. So next Saturday I will have an exam for you guys. Okay, you have to pass the exams before you are officially
given the certificate.
Given the certificate.
Grade sheet is there.
Grade sheet is there too. So please pay attention to everything I am telling you because I'm going to ask you this thing. Tell me whether this is a biologic or not a biologic. So pay attention to details here. Okay. They are highly specific. That's the beauty of biologics, right? They're very specific. Bigger structure, they have so many things to have this thing. But they are not given orally because if you give it orally, our digestive system will completely digest the whole thing. So they are given intravenously, okay, which is the bad thing. Okay, so examples are monoclonal antibodies like Herceptin, cell-based like CAR-T therapy, vaccines, recombinant insulin, right? Insulin is a recombinant protein. Erythropoietin is given for anemia. Okay, erythropoietin is given for anemia. Now this is an interesting slide here. So look at this thing. So these dark ones here, this dark blue ones, they are small molecules approved by FDA in 1997. Antibody based is red and non-antibody biologics afraid by FDA is in green and CAR-T is in orange. So now look at since 1997. Only 2 antibodies were approved and 5 antibody-based non-antibody-based biologics. The 98, 5 antibodies, 99, no antibody. But look at the red and the green, barely anything. Okay, no CAR-T, no CAR-T. Now here, for the first time in 2017, CAR-T was shown up. And look slowly how many monoclonal antibodies, all the antibodies and non-antibodies are being approved now. And PD-L1 and PD-1 is among these ones. So it's a very recent discovery, very, very recent discovery. Okay, so biologics market right now it is 349 or 25, we don't even know. In 23 it was 349.6 billion. Okay, and it is estimated to really rise very rapidly. So this is becoming a very, very hot emerging field. So one of the disadvantages of biologics, especially with monoclonal antibodies, are that they're so big they cannot cross the cell membrane. So specifically if you are using monoclonal antibodies, you have to target those things which are expressed at the cell surface, like EGFR receptors, right? So receptor-based drugs, you can easily use antibodies because they don't have to cross the cell membrane, they just have to bind something outside the cell. So this is antibody structure here. So these antibodies are too large to enter the cells. So if the receptors are outside the cell, the antibodies will bind. Antibodies are Y-shaped, you guys know that, right? Okay. So they act like magic bullets, locking into the specific markers on cancer and immune cells. So on one side they will bind cancer cells, on one side they will bind immune cells, and they will bring together because their hands are like this. So if they're binding both, they have to be together, and immune cell will kill the cancer cell. Okay, so these are some of the classes of biologics. Okay, so I wanted to tell you, yesterday you asked me about oncolytic virus, right? So number 2, I had something else, so I replaced it with oncolytic virus because I thought I should. But then I'll talk about this again in the third lecture. In the third lecture today. Okay, but keep in mind this is not all. This is just few classes of them. There are many other classes also. So let's start with monoclonal antibodies. So these are lab-made antibodies that target specific antigens which are present on cancer cells. Okay, so again HER2 is coming up. So HER2 receptor is overexpressed. So if you make an antibody, it binds there, it inhibits the signaling pathway. How many of you have heard of Humira? Has anyone heard of Humira? Have you heard, Venkatesh? Humira? This one.
No,
Yeah, because I have heard of it because the advertisement is always coming there for Humira, but I did not know what exactly it was at that time. Humira is also an antibody against rheumatoid arthritis. Okay, so this is a monoclonal antibody. So this is the monoclonal antibody which is specific for specific receptors. And once this bind, two things happens. First of all, if you bind it to the receptor can no longer send the signal downstream. That is one thing. Second thing, what happens when antibody binds, the immune system gets activated and immune cells come near that and immune cells will eat up the tumor cells. So it also elicits an immune response. So this is it has dual benefit here. Okay, so there are many kinds of antibodies, like they can bring two things together. They bind one tumor cell from one side, immune cells from this thing, and immune cells are in proximity, they will kill the tumor cells. They can directly bind tumor cells. They can act as cofactor, bind it, but then not let the signal go in. Okay, they can also bind to something and get inside the cell through endocytosis. They can piggyback and do. So there are many kind of different antibodies there. Okay, so we tell the story of the famous Herceptin. The trade name for this is trastuzumab. MAB, you know what MAB means? Whenever you see MAB, M is monoclonal, AB is antibody. It means it is a monoclonal antibody. Anytime you see MAB in the end, you know it is a monoclonal antibody. Okay, so this is the cartoon for layman, and then I will show you the actual thing which is happening. So basically HER2 is overexpressed in breast cancer cell lines, and HER2 leads to cell proliferation uncontrolled, but it also promotes angiogenesis. That's why shutting it down is so important. So under normal circumstances, cells grow and there is angiogenesis, but when Herceptin binds, all the pathways are shut down, including angiogenesis, and the tumor cells die. And this one is actually showing you what is happening with Herceptin. So this is HER2 receptor. So this Herceptin binds here to the receptor. So once it binds, see how it is binding. So normal case, it will bind like this. Two things will come very close to each other, and this kinase domain will phosphorylate this, and this kinase domain will phosphorylate this. So these are the phosphorylation. So they will phosphorylate, cross-phosphorylate, right? And then they will get activated and the signal will turn on. Now this binds it like this. So this is non-productive binding. They cannot phosphorylate. So basically they are logged in inactive conformation, and antibody binding is extremely tight, very tight. You cannot get rid of them. Once they bind, they bind. Okay, then once they bind, now the receptor is endocytosis. So once again, let me tell you that. So when you're cooking something in the kitchen, you smell it, right? And then the smell goes away after some time. Okay, and then if you leave the kitchen, go away for some time and come back, then you can smell it again. So why does the smell go away? So normal cases we have receptors. So we are smelling. After a while, when the receptors get engaged, this is the biological phenomena that the receptors will be endosized. So all the receptors will go inside, and then they will come and they will be recycled again. So if they are not coming back, if they are still inside, we cannot smell. Only when they are recycled back and they are up there, then we can start smelling it again, right? So if they get engaged, it is endocytosis there, okay? And then in some cases, it will just bring the immune cell also together, Okay, so there are many ways. So what is the pros? It is extremely specific. It can target undruggable targets. You can make antibody towards anything, which is even if something is straight, no pocket, you can make an antibody. Antibody will just recognize any surface, and you can make a very tight binder. Okay, and many biologics, when antibody binds, it brings the immune cells. So you are activating the immune cells too. Okay. The bad thing is that it is not an oral pill that you can take, so it has to be given intravenously. Usually, if it is like a cancer immunotherapy, you have to go to the special facilities and they will administer it. Okay, it is very high cost and it is pretty complex. It requires refrigeration and things like that. Okay, and then also sometimes when you are giving the antibody and it is circulating in your bloodstream, your immune system can get really activated and start attacking without the antibody reaching the target. So you can have a severe immune reaction also there. Okay, so now let's go to oncolytic virus. So oncolytic viruses selectively infect and lyse cancer cells while activating an anti-tumor immune response. So what you do is that in another lecture, I have a more detailed slide on oncolytic virus, which will show you 3 ways oncolytic viruses kill cancer cells. Go ahead.
I have a question regarding monoclonal antibody. So, like the tumor.
Oh, you have to speak. Please give that.
Hello. Actually, ma'am, the tumor is covered with the fibrous tissue, and the tumor microenvironment is very complex.
Yeah.
So, does the monoclonal antibody have the power to like invade inside the tumor? Because
yeah, so here is the thing, not all tumors are equally fibrous here. So like pancreatic tumor is actually, the tumor is this big and the fibrous thing is this big. This is actually true. The tumor is this whole thing, so any drug will be very hard to get into the pancreatic thing. Breast tumors are not like that. There is a microenvironment there, but these antibodies can get through that. And also the advantage is that it is poking out of the cell there. So it is very much there and it is turning on the signal. So it's a very active component. Antibody can access it. Yeah. Okay. So oncolytic virus here. So first thing is that you make an oncolytic. So what is the problem of the viruses? If someone is infected by the virus, they divide. Yeah, go ahead.
ma'am, can we say that?
Oh, you have to use that.
So, ma'am, can we say that the monoclonal antibodies will stay for a longer time, even if curing the disease, like in the bloodstream, they will stay for longer period?
They do stay for a longer period of time because I know personally of someone who is undergoing immunotherapy right now, and he's giving PD-L1 and VEGF inhibitor antibodies every 3 weeks. So it is staying in his body. So, but if you take a small molecule inhibitor, liver cleans it up very quickly. So oftentimes, many diseases we take 2-3 times a day. At the very least, we take once a day, right? So yeah, they stay in the blood for a long time. And also, so yeah, your question is very valid. In interest of time, I'm not telling you a lot of things, right? So what we do so that it is recognized as self. So we make these antibodies humanized. So they resemble our antibodies. So initially when the research was going in this direction, you cannot make antibodies in human to inject it in humans, right? You obviously cannot use human as controls. Like you cannot use humans to generate antibodies for someone else. The human will die. So we were generating in mouse and rabbit and things like that, right? But as we were sequencing and isolating human antibodies, we know exactly how human antibodies look. So now you can recombinantly make antibodies in your lab. Okay, so they are vectors which will encode for heavy chain and light chain together. And if you put that in E. coli, it will make the human antibody for you. So these are humanized antibodies. So they are not recognized as foreign by the immune system. So we know exactly which is going to trigger the immune system, and that is the part we change it to make it more self-like. So that's why they can stay for that long. But this is a very relevant question. Okay? All right. Oh, go ahead. Please say, yeah. Thank you.
When we are synthesizing the small molecules, we are told that they should obey the Limbisky's rule of 5. So
What effect?
When synthesizing or designing small molecules, we are told that they should obey the Limbisky's rule of 5.
Oh, yeah,
So
the rule of
for
5.
peptides, biologics, small peptides, is there a rule like that?
There are no rules because they vary from one end to the other end, right? So the rules are very different than what it is for small molecules. Okay, so when we are saying that they have to follow Lipinski rule and all of these rules, right? But PROTACs don't follow those rules. PROTACs are much bigger than that, but they are still very effective. So if you follow those rules for small molecules, the chances improve. But as you go more and more complex, you do different things to make them there. Antibodies can trigger a huge immune response. So we have tricked the immune system to recognizing them as self. So there is no general rule like we have it for small molecules, because the diversity is infinite there. Plus, think of it, it is not made by chemical method, it's made by the organism. It depends on organism's health. Every batch is different, you know? All right, so we are back to oncolytic virus. So what is the disadvantage of virus? Virus will go, and if it infects any cell, it will just divide it within that cell and make more virus. And because it has made more virus, the cell will rupture and more virus will be released. And then they will infect the neighboring cells and make the virus, and those cells will rupture and they will release more virus. So they are very toxic, right? So when these oncolytic viruses are made, they are made in such a way that they cannot replicate in normal cells. They can only replicate in tumor cells. So they go and infect tumor cells, replicate there, and kill the tumor cells. So just by being there, they kill the tumor cells. But then you can also add some toxin to the viruses so that when they replicate, the toxin part is released, and that further kills the tumor cells. So there are 3 ways they can kill. I'll tell you about that later on. The third part is that when tumor cells are killed, right, ruptured, then the tumor antigens will be exposed. Immune system will get activated. Immune system cells will come and kill it. Okay? So that's what it is. So infection of tumor cells, viral replication, tumor cells lyse, release of tumor antigens, immune cells get activated, you clean up the mess. Okay? Okay. The third thing is vaccine. Okay? So we know vaccine for many different things. We are using for cancer also. Okay, COVID-19 vaccine is not cancer vaccine, but we know about it. So what is a vaccine? Basically, you take dead tumor cells, you irradiate it so that the antigens are just there, but they are not enough to cause cancer because they're all dead, right? And then you inject them, the body has a strong immune response, antibodies are made, right? And then those antibodies will go and recognize the tumor cells, they will destroy it. That's the vaccine thing there, right? So this is what it is, that tumor cells you take, you kill them, you take the component, you add it, and now the body does the rest of the things. This is just to show the mRNA vaccine for COVID. So we were discussing it a few days ago, the pros and cons of mRNA vaccine. The biggest pro was it was very quick. It was very quick. Okay, because otherwise it takes many years, but you know, it was forced upon us to develop it very quickly. Okay, all right. Gene therapy, I'll go a little bit fast because I have one whole lecture after this devoted on gene therapy, entirely on gene therapy, because it is such an important topic. So here I'll introduce you, and then in that lecture I'll tell you, just like for 1 hour we'll just discuss gene therapy. So some of you were also asking me about gene therapy. So now with the advent of CRISPR-Cas9, cystic fibrosis can be treated. You just fix the gene. Okay, you fix the gene and it is done. Okay, so any of you have done transfection here or infection in the lab? Probably not, right? Okay, so there are, when you deliver the DNA in the cells, that process is called transfection, but that is transient. But if you take the DNA and package it in a virus and infect the cell, it gets integrated in the cell DNA and it is there forever. Okay, so usually when we deliver DNA to human bodies, it is packaged in viral vectors. So these viral vectors are harmless vectors. They are just delivery vehicles for the DNA. So the principle is that you deliver the DNA and the DNA will make the therapeutic protein. Okay, so there are many different kinds of gene therapy, and like I said, that is the whole one lecture devoted to that. So we'll go through each of these things in great details in the next one. Now let's come to cell therapy. These are all biologics. So CAR T therapy comes under cell therapy. So it involves the transfer of intact live cells into the patient, stem cell therapy, CAR T cell therapy. Okay, so what are the processes? So today I'll tell you about CAR T, but then I have a whole lecture, actually 2 lectures devoted to immunotherapy, and there I will show you the structure of CAR T therapy in details. Okay, so you will keep hearing about CAR T in many lectures, but those 2 lectures are just extensively on CAR T therapy. Okay, so I want to tell you a little bit about what is the meaning of autologous and allogenic patients. Okay, so suppose you want to take the cells and correct it in a patient. You have 2 choices. So let's say this patient has some problem in some DNA. So first choice is that you take out the cells from the patient itself, right? And then you grow it in a plate and you fix it. And once you fix it, you inject it back, right? So that is autologous. Okay, the advantage is that it is the same cell. It's patient cells going back, immune system is not going to get activated. So this will be no immune rejection. So that's the good news there. The bad news is there the patient itself is in a bad situation and you're taking cells out of that patient, and then we have to wait till it is fixed, right? And the patient may not have that long to live by the time we make the whole thing. It may take months to get it back in the patient. So it would be ideal that we have something made in the shelf and we just inject it in any patient without the fear of immune rejection, right? So we have to do something, because if we just put it so we take out cells from healthy patient, we engineer it, keep it in the shelf, and we give it to the whole population, they are likely to have a rejection thing. So we have to fix something in this. So we'll talk about this briefly. So here, for example, so this is allogenic. Allogenic means that you're taking from healthy patient and then giving it to the healthy people and then giving it to different individuals. Okay, so normally you take it out from whether a healthy person or and then or the patient, then you engineer it, you make special cells, then you put it back to the patient, and then then it does its magic and cancer disappears. So what is the principle? You remove the cells from the patient or from a donor, then you cannot take out a lot of cells, you have to grow them, you have to make them in a large population, then you purify it, then you make the genetically engineered cell line, and then you put it back in the patient. Make sense? Okay, so when we do stem cell therapy, that is how we do it. Okay, so stem cells are those that they will make more stem cells, but they always have the capability to differentiate into any kind of cells. So suppose somebody undergoes cancer therapy, right, and we do irradiation, so the organ is damaged. So we do stem cell therapy to repair that damage. Okay, so all right, cytokines. So when you do, these are cytokines are those proteins that modulate immune response like cancer and autoimmune diseases. So let's see that. What we do, this is a really untreated cancer. Look at the blood vessels, very bad situation. So now we add a cytokine which is interferon alpha. So interferon alpha comes in, it suppresses angiogenesis and it promotes cancer death. So if you have to make interferon, you have to make it in bacteria, right? So it is a biologic, okay? So these are cytokines here. Now fusion proteins, this is an FDA approved drug. So this drug is called Enbrel or etanercept. So this is TNF receptors fused with this IgG part here, okay? So this TNF R receptor, this binds TNF alpha with high affinity, and this fusion part, this IgG Fc region increases stability and serum half-life. So you were asking me how long the antibodies are going to stay in the bloodstream, right? So this part actually increases the stability. So what happens is that this is given in rheumatoid RA, rheumatoid arthritis. So in rheumatoid arthritis, TNF alpha levels are very high, and TNF alpha activates inflammation signaling pathways. Okay, so it leads to inflammation. So what you are doing, you are giving this receptor, and receptor is souping up all TNF alpha. So it cannot bind to the receptor, and inflammation signaling pathways is shut down. Is it making sense? You are basically sequestering all the TNF alpha from there. So this is a fusion protein there. Okay, this is another example. So you are giving a fusion protein attached to an antibody, and this is an enzyme. So there is an antigen on the tumor cell. Pay attention. So tumor cells have something special which is not present in normal cells. So you make an antibody, and antibody will attach there because, and antibody will only attach to tumor cells because only tumor cells have those receptors, right? But the antibody itself is bound to an enzyme. Okay. Now you give a prodrug. Do you know what is a prodrug? You know prodrug, right? So it is like a masked drug. It is not complete unless the pro part is released. So now prodrug is circulating in the rest of the body, nothing happens. But when it reaches the tumor cell, because of this enzyme, prodrug is now releasing active drug in the close proximity of the tumor. So the tumor cells can get the actual drug, but nowhere else the drug will be produced because the enzyme is missing. So the tumor cells die, right? So this is another example. Hormones, okay? So for example, breast cancer, right? Breast cancer feeds on estrogen signaling. So if you give so estrogen promotes signaling, but tamoxifen looks like estrogen, but it inhibits signaling. So if you give tamoxifen happens to be a small molecule, but if you can give hormone which mimics that actual hormonal structure, then it can inhibit it. So you can use biologics to inhibit hormonal signaling if it is toxic, right? That's what is shown here. So blocking hormone receptors like estrogen receptors, suppressing hormone productions, surgical hormone suppression, okay? So this is basically hormone therapy. This is also a biologic, okay? Do you guys know what is the meaning of adjuvant, neoadjuvant, and palliative? Anyone? Say that again.
Adjuvant word is compounds which were added to the drug or something.
That's okay. Just let me ask you, what is palliative therapy?
Symptomatic, to reduce the symptom, not actually curing the disease.
That is what is palliative. So palliative is the last resort. You cannot cure the disease, but you're reducing the symptom to just have a better quality of life. That is palliative. Like we have given up, we are just making the person comfortable, right? What is adjuvant? Adjuvant is the therapy which is given after the main treatment, like somebody is undergoing surgery and you give chemotherapy after that, just to make sure if there are any lingering cells, they die. That is adjuvant. But if you give it before that, then it becomes neoadjuvant, right? That is the meaning of it. So coming back to hormones, if you are inhibiting hormone signaling, hormone receptors, you will give hormone mimics there, okay? This is, see, estrogen is written as OESTRON. I think this is British way of writing it. So estrogen will start the signaling, tamoxifen will inhibit the signaling, okay? Then let's go to enzyme replacement therapy. This is the last biologic. So enzyme replacement therapy treats genetic disorders, especially lysosomal storage diseases. So in many cases, if I have to ask you define the function of lysosome, what would you say? What is the function of lysosomes?
Lyse all the cells, I mean the target cell.
No.
Immune cells.
No. Lysosome is an organelle in the cell.
Achha, okay, they have it have hydrolytic enzymes.
What is it?
Engulfed
So I tell my student it is a trash can of the cell, which has to get rid of all the trash, right? So, but the lysosome has very acidic pH because they have to degrade it. If the lysosome is not functional, they will collect all the garbage and they will become bigger and bigger and bigger and bigger, and the lysosome size will become bigger and the whole cell will be in very bad state. Imagine if the trash is not cleaned up, we will get infected with all sorts of diseases. So it's a very serious disease when lysosomes are not functioning properly. It is a genetic disorder, right? So there we do enzyme replacement therapy. So this is a really nice one. So we give the functional enzyme. So we are not fixing the enzyme which is wrong. We are giving the functional active enzyme intravenously. The enzyme enters the bloodstream and it reaches to the lysosome, the cell's recycling center. Okay, and then once it is there, it cleans up all the mess because the right enzyme is there, and the lysosome structure, which was so swollen, becomes the normal size. Okay, so now you are basically not changing the thing, you are just replacing with the new enzyme. That is enzyme replacement enzyme, accumulated substrate, it undergoes, and then your restoration of normal cell functions. Okay, now now you have looked at biologics and you have looked at small molecules, right? So small molecules are much easier to synthesize. They are much cheaper to do that. Manufacturing, it is like growing, biologics is like growing a rare plant. It uses live cells. They are sensitive to temperature, pH, high variability. Having said that, it is becoming very common these days. It is. But this is a very important slide, although it is written very small in here. So I'm comparing biologics versus small molecule drugs in precision medicine. These are large biologics, these are small. Biologics are extremely specific towards their target. Small molecules have off-target effects. Mechanism of action, they can block receptor interaction, they can inhibit protein-protein interaction, they can turn on an immune signaling, they can kill the cells. They're usually inhibited. They bind in the pocket and inhibit the enzyme active site. They are injected by IV. These can be oral. Oftentimes it is oral. Patient family. The onset of action, if you take a drug, a small molecule, it has a very fast reaction. This takes some time to build up and then it works, but it is longer lasting, weeks and months after dosing. Like I said, for immunotherapy, I know this person is taking every 3 weeks. This is, here we need to take daily. This is very costly, this is very cheap. There is unless you humanize the biologic, it can have an immune reaction. Okay, now this one, small molecule resistance are much easier to develop. Okay, so resistance develops by secondary mutations or efflux marks. In this case, tumors also become resistant to immunotherapy and other therapies like with biologic. but it is a little bit harder to develop resistance. Very expensive. This is a lot cheaper, and you know the examples already. Okay. So mechanism of resistance for small molecule is that, you know, if the small molecule is designed towards this pocket, the mutations will occur in this pocket so that they don't have to bind this molecule anymore. Okay. And in this case, what they do, if it is binding the receptor will change its structure, or it will not even show up those things. So wherever it is binding, those things will change so that it no longer binds. Just see how smart cells are. They just keep changing because they don't like to bind it. Okay. So now I'm going to show you one compound which combines the beauty of both small molecules and biologics, and that is ADC. ADCs are ADB drug, antibody drug conjugate. So it is a biologic plus a small molecule. So you are giving a monoclonal antibody, but you are attaching real toxic molecules to it. So now the antibody goes and binds there, it is internalized, the toxic molecule is delivered inside the tumor and it will kill it. That is ADC. Okay. So how ADC works? They are bind, they are internalized, they are released inside the cell, causing cell death. Okay. And this is bispecific. So bispecifics are BiTEs, bispecific T cell engagers. So on one end they will bind the cancer cell, on the other end they will bind the T cell. And when you bring the police right next to the thief, something has to happen there, right? Immune cell can ignore it from a distance, but when they are together, tumor cells will die. Okay, so this is, look at this thing. So they have made this here. So there are many kinds of bispecific antibody. So this is one part. Now they have chemically combined it to bind a different one. You guys know when you have antibody, this is the part which recognizes that, right? So if I am Y-shaped, this part is recognizing the antigen. So this part is recognizing a tumor, this part is recognizing immune cells. Okay, so pay attention to this, just the blue part and the red part. Rest, everything is the same. So this recognizes tumor cells, this one is recognizing the immune cells. Okay, and you can actually couple them together chemically. Okay, so and we have many variations of that. We can attach radioactivity, we can attach similar drug, we can attach dual drug. See, this is a bispecific antibody, this is just a regular antibody with two different drugs. So we have huge combination. We can attach fluorescent reagent, we can, so that we can see where it is going. We can attach the drug and the fluorescent molecule, right? So there are many ways to do that. And today I am also going to show you that the antibody themselves can be changed. Okay, so what is the biggest disadvantage of antibodies that you say? It's very big. So now we can make really tiny antibodies which work really well. Okay, now have you ever heard of biosimilars? Never heard of it. This is a very new word. So these biologics are very expensive, right? So biosimilars are also biologics, but they are less expensive, and they are similar, but they are not identical, and they are easier to make. So these biosimilars, when patents for major biologics expire, biosimilars are entering the market. They are highly similar copies that offer comparable efficiency at a reduced cost. Do you guys know about the patent and the generic drugs? Do you all know that? Is there anyone who has not heard of generic drugs? You haven't. So what happens is that when you make a drug, right? So with extremely few exceptions, it takes years and years and years and years of work to find a drug, especially for disease like cancer. Okay, so and hundreds and hundreds and thousands of people work, right? So you spend billions of dollars before you can find that one drug, right? But once you find the drug, it may be a piece of cake to synthesize it. So then everyone will start synthesizing it, but the company who made that thing is not going to get the money back. So in that case, no company will ever spend the time in developing a drug, because the moment they develop a drug, everyone is synthesizing it. So they apply for a patent. So that patent restricts the rest of the world, the whole world, to synthesize that compound, so that everyone has to buy from them. Okay? But once the patent expires, which is, I don't know, 10 years? 20 years. 20 years. Then the generic versions come, and then other people can synthesize it. And they can also modify it here and there. It depends on what the patent has used for protection, right? So then there are the generic versions, okay, that can have different formulation and this and that, basically the same drug. And they are at a very reduced cost. So for example, if you take thyroid medication, right, I can't even remember what is the name of the non-generic one, the actual one. Synthroid. Synthroid is the thyroid medication, but the generic one is called levothyroxine. So if you buy levothyroxine, it is dirt cheap. If you buy Synthroid, it is very expensive. But once the generic one comes, nobody ever will go for Synthroid because it's the same chemical, correct? So it is the same for biologics. So once the patent expires, then similar structures are produced. Suppose it is almost similar, but it is much cheaper to produce. Okay, is it making sense? Okay, so that's what it is. So this is just a new term which has just originated. It is highly similar version of an approved biological product, nearly identical structure, but may have slight natural variation, made after original patent expires. It is a generic version of small molecule drugs. Okay, and this is 15 to 13%, 30% less expensive. So one day, what do we want? That the biologics can also be taken in such a way that we don't have to go through intravenous injections. Okay, and because you go to the hospital to get it, it becomes super expensive. All right, and of course, AI, we need the help of AI in accelerated drug discovery. Okay, because these things can predict protein structures and identify hidden pockets for drug binding. All right, all right. So we have to synergize between biologics and small molecules. Synergy is the key here. All right, this is the end of the story.